Okay, thank you, Blair, for inviting me for this opportunity. Good evening, everyone. I will have a brief talk, new updates in management of hyperglycemic crisis, including decay and HHS in adults. This is a timely and a special topic this time for 3 reasons. One, we are celebrating the 100th year of insulin discovery. Insulin was discovered in 1921, so now is a 1 century old drug. The other is we have recently celebrated the World Diabetes Day, and there was shocking data showing an increasing diabetes worldwide, especially the developing countries, including Ethiopia. The third reason why this is timely is I have been attending a meeting recently that Ethiopia has received more than 50,000 doses of insulin, including insulin analogs. So we should know how to use it in decay and HHS states. This is the outline of presentation. We will see the epidemiology of hyperglycemic crisis, how it happens, the pathogenesis, some clinical and molecular lab features, how to treat it, and some of complication of therapy. So if you guys have questions, you can write it in the chat box or stop me anytime. Okay, so I will start the discussion with a case. The first case is a 20-year-old man who was diagnosed with type 1 diabetes 2 years back. He's on multiple daily injection, basal and bolus insulin therapy, and he ran out of insulin 2 days ago. This is an actual case, and he presented with an abdominal pain, some other GI symptoms with significant symptoms, and his mentation was getting worse since the day before. On admission, the vital signs, his BP was lowish. He has tachycardia. He is tachypneic as well, a low-grade fever, his mentation, he's drowsy, and he has also generalized abdominal tenderness. 50 milligram per day, he has mild leukocytosis of 18,000, the higher range, and he has also creatinine derangement with urine ketones strongly positive 3+, and metabolic acidosis. So what do you think is the diagnosis here? You can unmute yourself and answer. Okay, so it's good to have he's in type 1 diabetes. He ran out of insulin, so he has insulin deficiency. He has feature of dehydration, tachycardia. He has feature of acidosis, tachypnea, form of stress features, metabolic acidosis, ketosis. So this is a case of diabetic, classic diabetic ketoacidosis. Okay. So the second patient is a little bit atypical. He's a 47-year-old including dapagliflozin. He was on a strict diet for weight loss. He presented with several days of some urinary tract symptoms with poor oral intake. He had similar UTI 2 weeks prior, for which he was treated with antibiotics. On presentation, he's febrile, he's tachypneic, tachycardic, BP is on the higher side, and saturation is okay. His RBS was lower than the previous patient, 215. Creatinine is okay. The ABG shows acidosis with 3+ urinary ketone and blood ketone positive as well. So some of the treating physicians think he might have misdiagnosed type 1 diabetes. They send type 1 diabetes panels. GAD65 antibody test was negative. C-peptide showed preserved C-peptide level. So what do you think is this decay or not? Okay, the R base is mildly elevated, only 215. Any of you guys can unmute and have a say on this.
Hello, Dr. Melaku.
Okay.
This patient is on SGL2 inhibitors, and they may develop ketonuria. And even with low blood sugar, they may develop PDK, I think.
Okay, excellent. Dr. Abdu says?
Yeah, Abdu.
Okay, excellent, Dr. Abdu. I brought this case because nowadays we are seeing more between relatively newer agents, including the euglycemic diabetic ketoacidosis. We will have a discussion on this. Okay, you might see cases like this in towns. The third case is an elderly guy with long-standing diabetes on oral medication. He presented with diabetic foot ulcer with worsening of polysymptoms and generalized weakness. On examination, his hypotensive with right ulcer. His mentation was and the R-base measurement was greater than. So is this a diabetic ketoacidosis or HHS? So this is a classic case of HHS with mental status change, severe dehydration, and a significant stressor. I put this case later on as well, how to manage this. So hyperglycemic crises are acute metabolic decompensation of diabetes mellitus. So decay is caused by threats of hyperglycemia, ketonemia, and acidosis, whereas HHA hyperglycemia more severe than decay with high serum osmolality and dehydration. Okay, or little or no ketonemia. Okay, their common feature is absolute or relative insulin deficiency with volume depletion and acid-base abnormalities. Okay, this is about a little bit about the history of decay management. As you might remember, insulin was discovered in 1921 by 3 or 4 young physicians. Before that, diabetes was, especially type 1 diabetes, was fatal disease. They die of diabetic ketoacidosis in short weeks or months. After that, after insulin discovery, there was several algorithms of decay management. The initial algorithm was includes high use of high so high insulin therapy was adopted for decay, but later on a lower dose was found to be equally effective with lower complications. But the first comprehensive guideline on decay was put forward in recent years, 2001, by the American Diabetic Association, and the UK guidelines followed. Okay, now we have many RST evidences about the doses and the routes of insulin therapy and about fluid therapy. Okay, nowadays we have very low decay mortality. So a little bit on epidemiology. So decay is characteristically associated with type 1 diabetes, but it can occur with type 2 diabetes with severe stressors or even as a presenting initial type 2 DM called ketosis prone DM or KPDM. Okay, classically type 1, but it's possible with type 2 DM. Whereas HHS is characteristically happens in elderly type 2 diabetes. About the mortality, decay mortality is very low, less than 1%, whereas HHS mortality is 10 or 20-fold higher than decay. Okay, it's because of the severe dehydration, elderly patients with severe comorbidities. Okay. So this graph depicts the hospitalization and mortality of DK in US before some 5-6 years. So the solid graph indicates the so there was initial decrement up to 2010. After that, there is an increment in hospitalization, but the more or less than 1% nowadays, close to 1 point. So the overall decay 0.6 per 10,000 admissions, and the overall mortality is about 37 per 10,000. This is close to 3.37%. Okay. Look at some of the risk factors for mortality. Male sex is associated with higher risk of mortality. Being Black is associated with higher rate of mortality, and with increasing age, especially more than 85, it's associated with very high rate of mortality. Plus, the form of payment, those with insured and uninsured, in uninsured individuals, the risk of death is higher. This is a US data, more recent US data. Okay, why do we care?
I think yeah, Doctor.
Am I disconnected, Binia?
ተቆራርጦ ነው መሰለኝ። አሁን መግባት ትችላለህ። One minute.
Okay. Host enable አድርግልኝ። Host
እሺ ዶክ።
እሺ እሺ ኢኔብል አድርጌዋለሁ ዶክ።
ኦኬ ኦኬ ይታያል አይደል?
አዎ ይታያል።
እሺ ማይታይ ነገር ሲኖር ሲቆራረጥ let me know. Okay, so it's good to know the normal response to hyperglycemia. So when glucose increases for whatever reason, the first response is the beta cells, is the pancreas is the center of glucose homeostasis. So there will be increased insulin from beta cells, and at the same time there is decreased glucagon. Glucagon should be suppressed from the alpha cell. This results in decreased glucose production from the liver. Both the gluconeogenesis mechanism and the glycogenolysis mechanism is suppressed, and there will be increased glucose uptake in peripheral tissues, especially the adipocytes and skeletal muscle. The end result is normoglycemia. So DK and HHS is opposite of this physiology. Okay, I'm not sure how to hide. Okay, so the opposite of that normal glucose homeostasis is DK or HHS. I don't know how to make this thing go off. It's covering my slides.
ችግር የለውም በቃ ዶክ። You can continue.
Okay. Okay, so there are two things. Okay, so DKHHs are not just an insulin problem; it's a multi-hormonal problem. But the main abnormalities are absolute or relative insulin deficiency and increased counter-regulatory hormones, especially glucagon. So you know, insulin is the main anabolic hormone that's responsible for lipogenesis, protein synthesis, and glycogen storage. So when there's absolute insulin deficiency, there will be activation of hormone-sensitive lipase, resulting in increased lipolysis. This results in influx of free fatty acids to the liver, and the liver changes them into some of them into gluconogenic precursors, and the other into ketone bodies. Okay, this results in ketoacidosis and increases the gluconogenic substrates that goes to the liver, resulting in gluconeogenesis. At the same time, the peripheral, because of insulin deficiency, the peripheral glucose utilization is decreased, especially in adipocytes and muscle, resulting in hyperglycemia. Okay, so high glucose results in osmotic diuresis with loss to volume depletion and hyperosmolarity. Okay, so these are increased ketoacidosis, hyperglycemia, and hyperosmolarity. Renal function is a main pathophysiologic mechanism and manifestation of DK and HHS. The difference between HHS and DK is that in DK there is absolute insulin deficiency, whereas in HHS these are type 2 patients they have some preserved insulin, so the insulin deficiency is relative. So ketogenesis will be protected by very small remaining amount of insulin. So there won't be ketoacidosis. Otherwise, the other manifestations are the same. The other difference is hyperglycemia is more marked in HHS, and hyperosmolarity is more marked with DKA. Okay, this is a simpler diagram. So when there is absolute insulin deficiency, there will be increased glucose from gluconeogenesis, glycogenolysis, and decreased glucose utilization, plus hormone-sensitive lipase will be activated because of lack of insulin. This results in ketone body formation, leading to acidosis, whereas in hyperosmolar hyperglycemic syndrome, the insulin deficiency is relative, whereas the counter-regulatory hormones are there. So the ratio will be towards the glucagon. This results in hyperglycemia, but there won't be ketosis. There will be little or no ketosis because of the preserved insulin. Okay, this is a simple diagrammatic presentation to show you the ratio of insulin to counter-regulatory hormone, primarily glucagon. So when this balance is towards the counter-regulatory hormones, it results in all the hyperglycemia, ketosis, and resultant metabolic abnormality. Okay. One question was, is glucagon really essential for DKA to develop? It's not. This study shows, this very small study in 6 patients with type 1 DM and 4 patients with total pancreatectomy done was studied, and they look for if glucagon is really essential for DKA to develop. So as you could see in the first picture, insulin was stopped in both diabetic and pancreatectomized patients. So as you could see, the plasma glucose level didn't increase in in operated patients, whereas in type 1 diabetic patients, the glucagon level increased. This was translated to a higher or faster increase in glucose level in diabetic patients versus operated patients. Both of them has hyperglycemia, but the rate of hyperglycemia and the amount of hyperglycemia was less remarkable in patients, operated patients. Means totally pancreatomized patients don't have beta cells plus alpha cells, right? So no alpha cells means low glucagon. This results in, was translated to ketosis. So in patients, pancreatomized patients, the rate of ketosis development was slower, but they actually developed DKA later on. So it was proved that glucagon is contributory but not essential for decay. But mind you, when there's no glucagon, the rate and amount of hyperglycemia and ketosis was lower and slower. Okay. The other question is, why is hyperglycemia more severe in HHS? Okay, one thing is decay patients, they come early with symptom of ketoacidosis. The other is patients with decay tend to be younger patients with higher GFR, with preserved renal function. So they pee it out. They have higher glucosuria capacity, limiting the severity of hyperglycemia. The opposite happens in HHS. Okay, the other question is, why is ketosis not in HHS while the pathophysiological mechanism is the same? This is due to the differential sensitivity of fat metabolism and glucose metabolism to the effect of insulin. Okay, so very small amount of insulin is required to suppress lipolysis and ketogenesis. Okay, whereas a very high amount of insulin is required to inhibit hyperglycemia. So a very tiny amount of insulin in patients with type 2DM with HHS prevents ketosis and lipolysis, whereas it won't prevent the hyperglycemia. Okay, so what are the precipitant factors? These are the 7 I's. All of these factors start with the letter I. So it could be the initial presentation in type 1 DM, or as I told you, in ketose-prone type 2 diabetes patients. It could be due to inadequate insulin. You know, insulin is expensive, costly, unaffordable to most of the patients, so they tend to ration it with lower doses. Okay, the first patient, as you could remember, ran out of insulin few days prior to his admission. Okay, the other common precipitant is infection anywhere. It could be in the urinary tract or the chest, or the foot infection, as you could remember in the case example. The other is especially in elderly patients with cardiovascular disease. Think of cardiovascular events like myocardial infarction, stroke, or other cardiovascular events. Okay. The other is pregnancy. Pregnancy is a ketogenic state. Patients with undiagnosed unknown pregnancy could come with decay. Okay. The other is perioperative stress. The other I is intoxication or illicit drug use like cocaine can precipitate hyperglycemic crisis. The other is, as you could remember in the second example, drugs including SGLT2 inhibitors are incriminated to precipitate decay. Other drugs, commonly drugs like glucocorticoids, high dose thiazide diuretics, or recently cancer medications like the immune checkpoint inhibitors can precipitate hyperglycemic crisis. Okay, these are some of the clinical features. These patients have precipitated polysymptoms, polydipsia, polyphagia, polyuria, as hyperglycemia and ketosis worsens, the CNS depression. They would have blurred diffusion from hyperosmolarity. They would have deep, fast breathing because of acidosis. They tend to hyperventilate, and the breath will have a smell of ketone, acetone. It's like a nail remover like paste. Okay, they have GI symptoms that could mimic acute abdomen. These are some of the clinical features that you guys know of. Okay, this is a summary of the clinical features taken from Harrison. They have the symptoms, the precipitants you should be elicited, and on physical examination, they tend to have deranged vital signs with acute abdomen-like tenderness and progressively CNS depression. Initial laboratory evaluation in primary care setting includes checking the random blood sugar. CBC should be drawn to look for sign of infection. So leukocytes more than 25,000 with more than 10% band cells indicates acute infection. Otherwise, a mild elevation of CBC may not be indicative of infection, because decay is stressful by itself because leukocytosis. Okay, electrolytes should be sent, especially potassium level should be measured. Serum ketones, if possible. If not, urine ketones should be measured. renal function, and if the setting allows arterial blood gas analysis should be done. This is important for diagnosis plus to classify severity of decay plus for monitoring of decay resolution. Okay, if in an elderly, ECG is important for one thing. You could look until electroemia. The other is, we said that ischemia or MI is a common perceptant, so you should exclude that. And you should culture everything, including blood, urine, and sputum plus chest X-ray to look for focus of infection. Okay, so this picture depicts the difference between DKA and HHS in terms of body water and electrolyte deficit. As you could see, HHS has more severe volume depletion. Okay, the estimated water loss is close to 10 liters, whereas for that DKA is half of that, close to 5 to 6 liters. Okay, so all the electrolyte arrangements, especially sodium loss, is more severe with HHS. So these are some of the biochemical diagnostic criteria for DKA and HHS plus severity classification for DKA. The hyperglycemia, we have said that is more severe in HHS than DKA. It's more than 600, whereas in DKA it's between 250 and 600. Okay, whereas acidosis is worse in DKA. The pH is less than 7.3. As you could see, the severity increases, the degree of acidosis depends as well, whereas in HHS, there is mild or no acidosis, okay? About ketones, there is significant ketosis in DKA, whereas there is little or no ketosis in HHS, okay? On the opposite, osmolality is severe with HHS than DKA because of the severe volume depletion, okay? So these are the hyperglycemic, the DKA triads. It's characterized by hyperglycemia, ketosis, and high anion gap metabolic acidosis. There are differentials to it. DKA is not the only thing that causes metabolic acidosis. The common differentials are acute kidney injury, alcoholic ketoacidosis, and starvation ketosis. Okay, so these are the three common differentials: starvation ketosis, alcoholic ketoacidosis, and renal dysfunction. Whereas HHS is characterized by triads of severe hyperglycemia, more severe than DKA, significant pronounced remarkable volume depletion, and elevated serum osmolality with no or little ketosis. Okay, we have said, and Dr. Abdu was saying about euglycemic DKA. So it's a rare complication from some drugs, and you guys should be aware of it because of increased prescription of SGLT inhibitors. So it's a DKA with mild hyperglycemia. It's often less than 250. It can occur either in type 1 or type 2DM. And in the Western studies, it accounts for 5% of DKA admissions. Okay, there will be less remarkable symptoms and pronounced non-specific symptoms. They could come with fatigue, malaise, not the typical DKA symptoms you know. What causes euglycemic DKA is commonly is SGLT inhibitor, but significant starvation or carbohydrate deficit limiting the rate of hyperglycemia could result in euglycemic decay. Okay, in the longer fasting, starving, those on ketogenic diet. Remember, and second patient was on ketogenic diet trying to lose weight. Okay, those with eating disorder like anorexia nervosa, patients with diabetes, with autonomic neuropathy and gastroparesis has limited hyperglycemia. Patients with alcoholism has limited glycogen store, so the hyperglycemia will not be pronounced. Okay, and sometimes partial treatment. Patient could take insulin before, after developing DKA, they could take insulin before they came to the ER, so the hyperglycemia will not be remarkable, but metabolic and fluid abnormalities are there, so you should treat it. Okay, and sometimes that's SGLT inhibitors pregnancy because of excessive glycosuria. Glucosuria will be minimal. Patients with CLD have, okay. So these are some mnemonics for you guys to remember what could cause or what could precipitate SGL2 inhibitor-induced diabetic ketoacidosis in conditions that could worsen intravascular volume or ketose-prone states. Okay, this includes diarrhea, exercise would expose them to volume depletion, and whereas reduced latent autoimmune diabetes of the adults can predispose to ketosis. So you should choose your patients when you are prescribing SGLT inhibitors, especially stop it when there are significant stressors like hospitalization, surgery, not eating well. Okay. Now, goals. Always you should set goals so that you would know when and how to achieve them. Okay. The first goal in hyperglycemic crisis management is volume repletion. Okay. Fluid is the first line of care. The second goal is correcting electrolytes, especially correcting hypokalemia. Okay, because it is a heart-threatening condition. The third is insulin therapy, replacing the insulin deficiency. The other is fixing the precipitants, so that if you don't fix precipitants, the decay is going to recur. Okay, and the other is managing complication related to your treatment. So, patients with DKA needs vigilant monitoring, especially severe DKA needs an ICU admission. So the first thing is always securing the ABCs of life. You have to secure airway and oxygen supplementation. Might need ventilation as well as needed. And you should secure a large bore IV line, preferentially double IV line. Okay. You have to monitor the vital sign, fluid balance, ECG monitor is important, and neurologic status should be assessed every hour. Okay, serum glucose should be checked every hour, and ketones and other biochemical tests like electrolyte, ABG should be monitored often, every 2 hours. Okay, this is an example of a monitoring chart. So this is filled out every hour of patient progress. Okay, including vital signs, mental status, chemistry, including glucose, ketones, electrolytes, osmolality, anion gap, ABG profile, and the insulin, the route of insulin, and the dose of insulin infusion, and the type of fluid you are giving, the urine output, and others should be recorded and followed on hourly or every 2 hours. Okay, so the first goal we said is fluid therapy. So fluid repletion is the first essential step in hyperglycemic care, hyperglycemic crisis care. It's usually initiated with an isotonic saline, because starting hypotonic fluid initially worsens cerebral edema. So start with a normal saline. Okay, you can change it to 5 hypotonic fluid, like 5% dextrose, when the blood glucose drops to less than 250. Okay. Mind you, hydration alone can fix most of the problems. Okay, it reduces the level of stress hormones, and by this and increasing the renal perfusion with glycosuria, it also improves hyperglycemia. So it's the first step. Okay, what type of fluid and how much to give depends on the patient clinical condition, especially the initial hour of fluid infusion depends on if there is hypovolemic shock, you give bolus fluids, and based on the hemodynamic parameters, you can repeat it. If there is hypovolemia without shock, you can give 1000 ml within the first hour. If they are euvolemic, extremes of age with cardiovascular disease, heart failure, risk of fluid overload, you should administer fluids at slow rate. Okay, how to give subsequent corrected sodium. Okay, if sodium if there is corrected glucose in blood is hypertonic, it draws fluid from the intracellular space to the extracellular fluid. This dilutes sodium. So corrected means you should correct for sodium. The correction is done for every 100 increase in glucose above normal, the sodium will drop by 1.6 milliequivalent per liter. So after correcting that, if sodium is low, continue the isotonic fluid. If sodium is high, you can give electrolyte-free fluids like half NS or BNS. Okay, the second is electrolyte management. The most crucial electrolyte is potassium. Potassium abnormalities are multifactorial in decay, wanting insulin and acidosis. Shifts the potassium to the intracellular space. So there could be a low, a relatively normal potassium for severe overall potassium depletion. There's urinary loss and so on. So it's a very critical electrolyte. Okay, if potassium is below 3.3, give a higher potassium. If it's even in the normal range, you have to give KCl. The only time you don't give potassium is when it's high, in hyperkalemic state, more than 5.3, especially when there is renal dysfunction and no urine output. Okay. If patient has adequate urine output and you don't have electrolyte measurement, please give potassium. The third is insulin therapy. So you should delay insulin initiation until the potassium is above 3.3, because when you give insulin, you will worsen the hypokalemia, as insulin will shift it into the intracellular space. Okay, this could be could result in life-threatening arrhythmia. Okay, and in most patients with DK, a continuous intravenous infusion of human insulin or regular insulin is the treatment of choice. Okay, the route is intravenous, and the type of insulin is regular human insulin. Okay, this is the most preferred therapy for a majority of patients with DKA. Okay, there is no really significant clinical advantage of rapid-acting insulin analogs over regular insulin for DKA management. Okay, the other question is what route of insulin is recommended? Is it intramuscular, is it subcutaneous, or IV? Okay, most of the studies for hemodynamically stable patients show similar efficacy and safety. This is for mild hemodynamically stable patients. Otherwise, for severe DKA patients, intravenous route is recommended, because the subcutaneous route will not result in reliable absorption because of the dehydration and so on. Okay, so intravenous insulin achieves, steady state concentration in faster time and with more rapid decline in blood glucose and ketone bed, especially in the first 2 hours of treatment. Okay, so when we are giving non-IV insulin therapy, especially in primary care setting, when you don't have access to continuous insulin therapy, an initial loading dose or priming dose of IV loading dose of insulin is recommended to achieve the steady state concentration faster. Okay, what about giving IV bolus if you are going to give continuous therapy is not clear, and probably it's not going to be beneficial. So these are the references for the evidence. Okay, so beside intravenous, continuous intravenous regular insulin is the treatment of choice for DKA and HHS. How much to give is it's often started by giving 0.1 unit per kg IV bolus initially, followed by 0.1 unit per kg per hour continuous infusion. Okay, you can prepare insulin in normal saline or hypotonic fluids in 1:1 ratio. For example, you can add 100 units of insulin in 100 ml of normal saline. Okay, then you plug it to the perfusor. So what effect do we expect after giving this amount of insulin? The RBS reduction is expected to be 50 to 70 milligrams per day per hour. Faster than that reduction is not recommended because of increased risk of cerebral edema. Okay, if RBS is not getting lower at this rate, you have to increase double the infusion rate until this 50 to 70 milligram per hour reduction is achieved. What to do when the RBS gets down below 200 to 250? Lower the infusion rate. Okay, and change the fluid to dextrose containing solutions. Okay, how long to continue the continuous infusion? Until ketoacidosis is resolved. and the glucose is lower than 200. Okay, and you have to start subcutaneous insulin before continuing the IV insulin. Okay, what about the use of fast-acting insulin analogs in severe decay? There are no studies to support their use, so they are not recommended for moderate to severe decay and IV route. So what about giving them subcutaneous? Because of the dehydration, the subcutaneous absorption will be slow and they are not recommended. Okay, so use commonly found cheaper old human insulin, regular insulin for severe to mild, moderate to severe decay. What about mild decay? Subcutaneous insulin is possible, either regular insulin or the rapid-acting insulin analogs. The lispro aspart brilisine is possible in mild decay, subcutaneous route, not IV. Okay, the problem is in dehydrated patients, the subcutaneous absorption is impaired. So what insulin to use? Use regular insulin, if possible, continuous infusion. Okay, these are some of the criteria to use subcutaneous rapid-acting insulin, because in the beginning I told you that we have a donation of more than 50,000 doses of rapid-acting analog insulin, including rapid-acting insulin. So you guys should be familiarized how to use them in decay. Okay, the only indication is to use them in mild decay, subcutaneous route. Okay, when the patient is alert, able to tolerate oral intake, there is no significant acidosis with pH above 7 and mild acidosis with bicarb above 10. Okay, this is a dose of rapid-acting insulin. Initial bolus 0.3 per kg, followed by maintenance 0.2 unit per kg every 1 to 2 hours. When to lower the glucose, when to change the fluid to DNS is the same as that of regular insulin. The other is fixing the precipitants. Okay, if you have focus of infection, treated with antibiotic, adequate treatment of the physical stress like surgery, burn, trauma, and so on, and psychological therapy, psychosocial support therapy is recommended, because especially type 1 diabetic patients in puberty, they have a problem of body image, gaining weight from insulin. That's why they stop insulin and go to decay. So that you have to counsel that. Social stressors should be addressed, and school-age children during exam time have significant stress with insulin missed, resulting in decay. So you need psychosocial support, okay? And you should provide a quality health education about dosing and not to miss insulin, so that you prevent subsequent decay. So this is a summary, more complex when you look at it in the first place from up to date. So the first thing is to give IV fluids. Okay, what type of fluids is isotonic fluid? How to give it depends on the volume status. Okay, if there is a significant shock, give bolus fluids. If there's hypovolemia, you give about 1 liter in the first hour and subsequently based on hydration status. The second is correcting electrolyte. If you have adequate urine and no electrolyte measurement, please give potassium. The only time to stop potassium is if you have hyperkalemia, more than 5.3. The third is insulin therapy. So IV route is the most preferred route. So you give 0.1 unit per kg bolus followed by 0.1 unit per kg per hour continuous infusion. Okay. For mild decay, you can use a subcutaneous route, as we said. Rapid-acting analogs can be used. Okay. For how long to continue insulin therapy? Until the ketosis is resolved, the hyperglycemia has come down to less than 200, and mental status improved in patients with HHS. Okay, so what are the criteria for resolution of decay? We said glucose less than 200. For patients with HHS, we can keep the glucose about 250, because too much lowering from too high can result in cerebral edema. Okay, and ketosis has resolved with normalization of anion gap, and blood keto level has resolved. Okay, and normalization of mental status, and patient able to eat. Okay, urine ketone testing is not recommended for to document resolution of decay, because the testing used for urine ketone is a nitroprusside test. It reacts to the slowly cleared acetone. from urine. So it's not, if you still have +1, +2 urine ketone with normalized glucose, normalized mental status, it's okay to shift to subcutaneous insulin. But when you are initiating subcutaneous insulin, you have to overlap the IV and subcutaneous insulin, okay? For at least 1 to 2 hours, overlapping is recommended because the absorption from subcutaneous insulin takes time, so that they could rebound or go to decay again if you don't overlap, okay? How to initiate subcutaneous insulin? If there are new patients that initially present with decay, you can start a multiple daily injection with basal bolus insulin regimen at a dose of 0.5 units per kg per day. Or if they were a known patient, you can start a pre-decay or the previous insulin dose. Okay, so this is a national algorithm for decay management. The criteria are the same: hyperglycemia, ketonuria, 2+2 or more ketonuria and glycosuria, and HHS severe hyperglycemia more than 600. Change mental status and dehydration are the diagnostic criteria put forward in our Ethiopian national guideline. And laboratory parameters are the same as what we discussed. The monitoring is the same: blood glucose every hour, ketones every 2 hours, and vital sign and fluid status monitoring. And the insulin regimen put forward. This is for health center and primary care setting. Okay, in hospitals and above, you can use a continuous insulin infusion. So the initial bolus is about 10 unit IM and 10 unit IV, followed by 5 to 10 unit hourly IV insulin, regular insulin bolus. Okay. The diagnostic criteria for resolution and when to switch to subcutaneous insulin is the same as what we discussed before. So what are the complications? So cerebral edema is a common fatal complication in children. Okay, it's rare in adults. The mechanism of cerebral edema is because of changes in the tonicity in the brain. Okay, rapid glycemic drop, rapid electrolyte changes, the fluid we are pumping, all of these results in cerebral edema. The initial clinical manifestation is headache with change in mentation, and some of focal neurologic deficit could be there. How to treat it is one thing is initial cautious fluid administration and glycemic management. The other is ICP management, including mannitol, of bed elevation, if it's not picked and treated early. The other is overzealous insulin administration can cause hypoglycemia. Electrolyte arrangements we discussed can cause arrhythmia, fatal arrhythmia, if not picked and treated timely. Okay, the other is because of the dehydration, the shock state, acute kidney injury is possible. The other patients with decay and HHS that are increased of infection with sepsis, aspiration, and notorious fungal infection, mucormycosis, could happen in patients with hyperglycemic crisis. Okay, so this is the end of our discussion. Why do we discuss this hyperglycemic crisis? Because these things, the prevalence we said in the Western, even in the Western, is increasing while we have insulin for more than 100 years. Okay, one of the reasons is because of access to insulin and other essential diabetes therapy is still limited. So this was the theme of this year's World Diabetes Day. Okay, the access to diabetes care, if not now, when? Okay, የስኳር ሕክምናና እንክብካቤ ተደራሽነት አሁን ካልተገበረ መቼ ነው? All of us should advocate for our patients. We should all our insulin requiring patients should have access to it for free. Okay. Thank you for listening. Any questions raised?
Thank you so much, Dr. Melaku. If anybody have a question, I think people are already raising their hands. You can unmute yourself, Dr. Tamru. You can unmute yourself and ask.
Thank you, Dr. Melaku. It's a nice presentation. I want to raise one question in our setup. Strength when managing severe decay patient, we use usually on insulin 10 international unit IM and IV start, following with 0.1 insulin or 0.5 international unit every 1 hour. Is there scientific background about using 10 international unit IM and subcutaneous? Thank you.
So I showed you in one of the slides that both the intravenous, intramuscular, and subcutaneous route of insulin administration were studied, compared in several small clinical trials. So the outcome the major outcome was resolution of decay and the time to discharge, time to decay resolution. All of the studies results in the same finding. The only difference was in the first 1 to 2 hours of decay management, the rate of R-based decline and the rate of acidosis decline was better in IV route. Okay, that's why IV route is more advocated now. So it's possible to use any of the routes, especially in mild decay. They can even be treated with the subcutaneous route.
Okay, thank you.
Great. Fasil Getacho, you can unmute yourself and ask your question.
Okay, thank you. It was a really nice presentation. My question is on the management of DKA, particularly in decompensated patients, especially in pediatric patients with severe acute malnutrition, and in adult patients with cancer. Is there any difference in the management, especially with regard to the fluid and electrolyte administration? That's my question. Thank you.
I'm afraid I might not answer your question well because I don't practice pediatrics no more. But one thing I could remember is you should be cautious with fluid therapy because these patients are at risk of fluid overload. If anyone around from pediatrics, they can help you more.
Okay, thank you, doctor.
Dr. Tigist Bacha is here with us. If you can ask your question, and you can unmute yourself.
Thank you.
Okay.
Okay, thank you, Dr. Melaku and Blue Hills, for the nice presentation. I learned so much. I'm from pediatrics. Regarding malnutrition, I think it's still a difficult question. There are some case reports and so on, and it's still challenging. Do we need to give the same amount of fluid and so on? Is like still a big debate. But we tell people, like, I mean, our physicians to be really careful when they give IV fluids for severe decays. And for mild one, we try to manage with PO. So that's what we do. But and I have one question, Melaku, like you said when random blood sugar is less than 250 to use 5% dextrose. Is that with normal saline or with half normal saline or with just plain? Because I see often like people put 5 DW, and which is a very hypotonic fluid for a DK patient. My other question is like we usually teach to decrease the insulin infusion if the patient is unresponsive for hypokalemia despite potassium administration for severe hypokalemia, or if the random blood sugar drops by 100 milligram per deciliter per hour. Usually these are the two challenge, I mean, time that we, or if the patient is really hypoglycemic despite our increment of the glucose concentration. But what is your practice in adults? Like, when do you like to decrease? For all less than 200, or do you have a specific reasons?
Thank you, Dr. Tigist. You have been an inspiration to me and all of us in Kurambasa. And nice to see you again. It's a privilege to give a speech with you in the stage about to what fluid to add dextrose. It depends on the electrolyte panel. If the sodium is, we said that if the corrected sodium is low, you have to continue using isotonic fluid. So it depends on the sodium status of the patient. If the sodium, corrected sodium is low, you have to add that glucose dextrose into an isotonic fluid. About the second question, I'm not sure if I catch right.
Dr. Tegist, you're still muted.
Okay, I saw some questions on the chat box. The first thing is from.
Oh, there's also someone who raised his hands. Maybe we can take him, and after we can go to the Dr. Gaetane Tafasa. You can unmute yourself and ask your question.
Dr. Melaku. Is it audible?
Yes, we can hear you. Continue your
question. Yeah, thank you for your nice presentation. And my question was, when DKA management, it should be, the patient should be out of DKA within the first 24 hours. If the patient is not out of DKA within the first 24 hours, some physicians recommend the patient to give PO feeding and then restart the management. Can you clarify this one? Thank you.
Thank you, Dr. Gaetane. This is, I practice an evidence-based medicine. What you said is a personal practice, but so we should all adhere to the evidences that support better outcome. Okay, so DK and HHS should be resolving as much as they were occurring. We said DK and HHS evolve over 24 to 36 or 48 hours. So they should come out of that at the same time. Okay, so if they are not resolving, there is a mismanagement. So that's why we have this update as well.
I think another one raised his hands. Omar Mohammed, you can unmute yourself and ask your question. You are still muted. Omar, you are still muted.
Okay, thank you. I think you can hear me now.
Yes, continue.
Okay, I want to thank Dr. Melaku for his really nice presentation. And my question is regarding the practice of this PO fluid administration. What are the evidences in studies, practices, as Dr. Tegist also mentioned, especially in severely malnourished patients? We usually see practices during my internship practices in different schools. I also saw that pure management of fluid. So what are the evidences, and is there any studies, and are there any practices outside our country for that? Thank you very much.
Thank you, Dr. Omar. So mild decay usually resolves over 6 to 12 hours, and patient alert, able to take oral PO feeding and fluid, can be treated with oral fluid and subcutaneous insulin only for short time. They can stay in the ED for 6 to 12 hours and discharged early. Okay, if there's nothing else to make them stay. So the point is there is no one size fit all fluid therapy for all patients with decay. It depends on the severity, the perceptant, and the response to our oral therapy and subcutaneous insulin therapy. So this, what you said, is for patients really well with mild decay patients that can be discharged early as 12 hours from the ED. Do you have evidences in our country? I don't think we have good evidence on any topic in our country. We use the Western data. So this is an assignment for all of us.
For the mild, there is ISPAD, International Society for Pediatric and Adolescent guideline. It recommends for mild decay to give fluids which are like ORS or home-based fluids, or if it's also for moderate, if in really primary hospital, I mean low-level resource places, during their referral to give that one. Otherwise, based settings, they use maintenance IV fluid with maintenance fluid, thinking mild dehydration has 5% dehydration, they add on their maintenance 5%. If it is moderate, around 7%, and in severe cases 8.5 up to 10% deficits will be added on the maintenance. So the fluid in IV is a little different for mild, moderate, severe, but for mild ones it's possible also to use pure fluids. As far as the kidney is working, IV fluids also can be used in mild cases, considering the deficit as 5%. Thank you.
Great. So we have
to augment.
Okay, continue.
Sorry, to augment this talk, we often advise patients to have in the Western setup a home urine ketone testing ketometers. Okay, so if they have mild hyperglycemia, mild ketosis, they can even treat it at home with increased fluid intake, with any of the fluid formulations that Dr. Tigstav said. Okay, so mild is not worrisome if it's treated early. Some of questions from the chat box. The first question is about modified sliding scale after they are shifted to subcutaneous insulin. I think we should, you guys should all delete sliding scale from your vocabulary. So there is no recommendation about sliding scale. Sliding scale is you slide with the sugar and you correct it after the hyperglycemia has occurred. Okay, it's a retroactive action. So in diabetes management, we should be proactive, prevent hyperglycemia from the beginning. Okay, so you should put them on basal insulin plus prandial and correction as needed. There is no sliding scale in diabetes vocabulary anymore. The second question is hypercoagulability in decay. This is a very nice issue raised. So decay and HHS are characterized by hyperinflammatory condition. Okay, there is increased inflammatory state, increased cytokines. This is any form of hyperinflammatory state, including COVID, as you might know, is associated with hypercoagulability. So they are at increased risk of hypercoagulability. So all of our admitted patients should be on prophylaxis heparin. The third question is rate of KCl infusion. If you are talking about primary care setting with a small peripheral IV line, you can go as high as 40 to 60 milliequivalent in larger amount of fluid. Otherwise, larger amount of KCl should be given in central line. The last question raised is also important. What about fluid management in already fluid overloaded states like heart failure and CKD? We said there is no one size fits all fluid approach in hyperglycemic crisis. So you should individualize and it should be based on the fluid status. You don't pump all that calculated 20 ml per kg and so on for an already overloaded state. So you should individualize based on the patient's fluid status. You are right. In patients with CKD and extremes of age, heart failure, malnourished, you should be cautious with fluid administration. How much to give depends on your monitoring, okay? Hemodynamic status monitoring. Thank you.
Okay, great. I think we have a limited time. We've already gone past 1 hour, so we would really like to thank Dr. Melaku for this amazing presentation. I hope we all got something from it. We could have took some questions, but we have a really limited time. Maybe on the next session, we can invite another guest and we would have more time. We thank you all for your participation. I hope you guys got something really important from this webinar. And as Blue Health, we will continue providing this kind of webinars in the future. And if you have any kind of comments on the webinar or on who we can invite on the next or on the future webinars, you can comment us. And thank you all. Have a great night.